Good afternoon, everyone. Welcome to the third and last webinar of our first Women's Health in Focus webinar series, hosted by the Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sharon. I'm the Associate Dean of the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing best clinical care for patients. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Navajo, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as parts of Treaties 6, 7, and 8, and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So I'd like to go over a little bit of housekeeping for our webinar. Please use the chat feature in the bottom of the screen if you have any technical difficulties or questions about L3PLP programs or services. If you have a question for the speakers, please use the Q&A feature of the webinar. Please review what's already been asked and upvote questions you'd like to have answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be sent together with the PEARLS document to the email of all those who registered, and subsequently will be available on our L3 webpage. Participants can claim CME credits and complete a personal development activity using the My Lifelong Learning Plan tool. So for more information, please visit the QR code on your screen. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. Additionally, Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise in your Main Pro Plus portal. So today we're very excited to welcome back Dr. Annick Poirier and her colleagues Analicia, Bozzo, and Alison Connors. We're going to discuss effective screening for female urinary incontinence, how to use the new clinical pathways, and key management strategies with community resources, and when we should be referring to specialty care. So Annick is a urogynecologist at the Lois Pole Hospital for Women at the Royal Alexandra Hospital. She also practices in the Lois Pole Hospital Chronic Pain Program. She's an associate professor in the Department of Obstetrics and Gynecology here at FOMD at U of A. She graduated from the Faculté de Médecine de l'Université de Montréal and did a residency in obstetrics and gynecology at McGill University. She worked as a general obstetrics and gynecologist physician for 5 years in the Gaspésie in Quebec. She completed a urogynecology fellowship through the Faculty of Medicine and Dentistry here at U of A. And her research interests are broad, but involve a lot of different qualitative methodologies, global health access to care, and chronic pelvic pain. She's currently now co-creator of the obstetrics and gynecology clerkship at the medical school. So thank you, Annick, for doing this. Analicia Bozzo is a registered nurse with experience in both acute care and primary care settings. She's been a consultant with the Provincial Pathways Unit team since 2002 and supports co-design of clinical and patient pathways for primary care providers and patients in Alberta. Analicia brings nursing expertise in internal medicine, pulmonary medicine, chronic disease management, and case management. And she's living with her husband, son, and dog in Calgary, and enjoys crafting and spending time outside. And Alison Connors, a wonderful old friend and colleague of mine who was previously at the Provincial Bariatric Unit, is a clinical nurse specialist now with the Provincial Pathways Unit in Primary Care Alberta. And she works to support the co-design as well of these clinical and patient pathways with diverse constituents, primary care providers, consultants, patients and family advisors, etc. And with her nursing background's broad, includes public health and pediatric weight management, and has been active in primary care forever. She lives in Edmonton with her husband, 2 children, 2 cats, and enjoys running, knitting, and spending time with family and friends. So thank you guys so much for taking time today to share all of your wisdom with the group. And I'm going to turn it over to you.
Thank you, Denise. Thank you for the introduction. Thank you for having us. We're very happy to be here, very excited to share the work that we did on the provincial pathway for female urinary incontinence. We're going to start with some objective for the presentation. We're hoping that all of you are going to be able to recognize the importance of screening for female urinary incontinence in primary care. Hopefully you'll be more comfortable with the provincial pathway, how to access it and use it. Hopefully you'll be more comfortable with managing your patient that presents with urinary incontinence in the community, and you'll know when to refer to specialty care appropriately. So increasing awareness of urinary incontinence is so important. Obviously, I'm preaching for my little bit of medicine, but at least 1/3 of women will have urinary incontinence at some point in their life. Patients are often reluctant to initiate discussion about their incontinence and urinary symptoms due to embarrassment, taboo, lack of knowledge, and often fear of management, such as surgery. Incontinence affect quality of life significantly. It's a cause of fall, of loss of independence, as well as social isolation. Care for incontinence can be done in the community safely in most circumstances, and it will overall improve timely care access for all women, either in the primary care setting or in the specialty care setting.
Okay, so we wanted to just take a few minutes to share a little bit about how this female urinary incontinence provincial pathway came to be. And so we have a bit of a timeline here on the slide. So starting in 2021, there was actually a female urinary incontinence clinical pathway that was developed by Specialist Link for Calgary's own. And in 2024, that pathway was due for review and updating. And at the same time, the Edmonton Zone Medical Staff Association, their Women's Health Committee, had approached the Provincial Pathways Unit to develop a provincial female urinary incontinence pathway. And so it was a really unique opportunity to take the really great work that the Specialist Link team had already done in creating a Calgary Zone pathway, looking at updating the pathway based on new guidance that had come to be in the last few years, and also look to expand the scope of the pathway to be provincial in nature so that it could be used across the province. And so that brings us to 2025, where we now have a clinical and corresponding patient pathway for female urinary incontinence that is accessible. So who is the Provincial Pathways Unit? So we wanted to share a little bit about our team. We are a small but mighty team. We were established in 2022 and we're part of Primary Care Alberta. We have a breadth of experience across the team, people with experience in nursing, backgrounds in paramedicine, OT, etc. And really our mission is to standardize, coordinate, and enable the co-design, the access and the utilization of clinical pathways, patient pathways, and referral pathways. So really, we just want to focus on, developing pathways and making them accessible to primary care. And so we do that by having a few minimum specifications that I'll kind of share on the screen here. So first and foremost, all of our pathways are co-designed. So what that means is they're co-developed with appropriate representation in specialty care, primary care, and patient and family advisors. So we typically have a minimum of 2 PFAs, ideally rural and urban representation. Same with 2 specialty and 2 primary care representatives, again, urban, rural, where possible. And our pathways are all developed with a standardized template, and we use standardized processes. So our template really aligns with the mental models that primary care physicians tend to follow when they're working with patients and, in consultations and kind of navigating a patient's health. Again, as I mentioned, our pathways are all designed to be used in primary care. And all of our pathways are housed on electronically on Alberta's Pathway Hub. So Alison will pop that link in the chat if anyone's interested in taking a look. So So in terms of the wonderful team who developed the female urinary incontinence pathways, you'll see everybody listed here. Our patient and family advisors, Alta and Rosemary, they were so instrumental in our work. From specialty, we have Dr. Annick Poirier and Dr. Charlene Linden. Primary care was Dr. Teresa Watson and Dr. Lila Rossi. And then from the Provincial's Pathways unit, it was Alison and myself. We also just wanted to send a quick but very important thank you to these other groups who were so instrumental in really supporting the development of this pathway and shaping these pathways to be really relevant and applicable to primary care and for our patients. So thank you so much to these lovely groups who really supported the development of the work as well. So here you can see a snapshot of the first page of the female urinary incontinence pathway. So you'll see that the first page is very algorithmic in nature. It kind of walks through kind of a stepwise process that physicians would tend to take from collecting history and investigations to understanding what management therapies are available for that condition. You'll see these toggle buttons at different points on the page, and that will link you to the expanded details. So this is the first page that is meant to provide like a snapshot and allows you to really work and utilize the pathway in real time when your patients are kind of sitting in front of you. And there's also expanded details that offer more guidance and more context where needed. One thing that I will mention as well is all of our pathways go through a very regular review process. So there typically tends to be a 3-year review cycle at minimum. But of course, we will bring the group back together earlier than that if there's changing guidance that is needed, that needs to be reflected in the pathway, just to make sure that our pathways continue to be up to date and sources of truth and evidence informed for our end users. So what we'd like to do for the rest of the session, or the majority of this session, is to actually walk you through, how you might use this patient or this clinical pathway if you have a patient. So we're actually going to walk through the pathway by following a case scenario. And so we're going to follow Maria, who is a patient who's just finished her consultation with her physician.
Maria, we're almost finished with our visit. Was there anything else that you would like to discuss with me today?
Well, this is really hard for me to talk about, and maybe it's just a normal thing given my age, and I've had 2 children, but I've really been struggling with this for a long time, and it just seems to be getting worse.
Can you tell me more? Are you willing to share a bit more with me? What have you noticed?
I leak pee when I do things like running or like lifting things, and sometimes I just get this sudden need to pee, and I run for the washroom, but I just can't make it on time. It's so embarrassing. I've stopped going to the gym. I have to carry an extra set of clothes with me everywhere I go just in case. I'm always worried that people around me are going to notice or think I smell like pee. I've tried things like cutting back on drinking water, and I do wear pads, but it doesn't help much, and I'm kind of to the point I just don't know what else to do. Can you help me?
Yes, absolutely. Let's have a look at the provincial pathway and see what we can do. So most women that you will see in your clinic with incontinence will present with chronic leakage with a slow onset over several years. Symptoms are often worsen around perimenopause and menopause. And if the presentation is acute, there might be reversible causes of incontinence to rule out. For example, common one include infection and constipation. If anything, all of you are probably more comfortable than me with doing this, but that should be the first thing to take into consideration. All the patient that presents with urinary incontinence will require a pelvic exam. Often we recommend that the patient has a comfortably full bladder. It will help when you get to the stage of doing a cuff stress test. So if we look into the pelvic exam into a little bit more details, of course, we always recommend to have a trauma-informed approach. This is a broad statement to make in a talk when I don't have a lot of time to talk about this in details, but I think the most important thing is to listen to your patient and work with them during the pelvic examination. The first step is to have a look at the vulva. You'll often find skin changes in patient with incontinence. They can be rash associated and excoriation associated with the urine leakage or the use of pad. There can be also changes that are common around the age of menopause. So things like lichen sclerosis and vulvovaginal atrophy are very common finding. We do recommend doing a cough stress test. This is simply making the patient cough with a somewhat full bladder. Don't forget to move aside. I've been pee on a few times. And really, if when they cough, there is some urine coming out, that's positive. And you know that the patient has stress incontinence for sure. You can then carry on with a more classic exam. So typically you'll do a speculum exam, have a look at the vagina and the cervix, again for vulvovaginal atrophy and an assessment of the tissue. You can have the patient do a Valsalva and look for prolapse as well. Most urogynecologists will do what we call a POPQ exam, but I don't think that it needs to be that detailed in the community. We do recommend palpating the muscle inside the pelvic floor muscle, and that's usually done with one finger. If you're comfortable, you can even take that opportunity to coach your patient on doing a Kegel exercise. Most women don't know what muscle we're talking about when we talk about pelvic floor muscle and can't find them unless they're coached quite extensively. And it's just a great opportunity to raise awareness of the importance of those muscles. And then a bimanual exam should be done as well. You're looking for things like pelvic mass and enlarged uterus that can put weight on the bladder and worsen some of the symptoms. I just put a picture for you guys so you have a sense of what a single digit manipulation. In this picture, interestingly enough, they are doing it with two fingers. I usually do mine with one finger, but they're palpating some of the muscle of the pelvic floor muscles. If any of you are interested about being more comfortable with pelvic examination, please let me know because we could potentially put on a workshop for that. There we are. First questions to make sure that you're following with me here. Which of the following is a red flag requiring urgent referral? Mild urgency and frequency, new onset of urinary incontinence during a viral illness, continuous leakage after pelvic surgery, and symptoms only with coughing. I think we'll give you a couple of minutes to answer, and then we should have the answer. We should have the...
Perfect. I'll just share this now. We have quite a few responses.
Okay, excellent. Thank you. Okay, 2% of you said mild urgency and frequency, 6% new onset of urinary incontinence during a viral illness, 91% continuous leakage after pelvic surgery, and 0% when symptoms occur only with coughing. So mild urgency and frequency is very common in women. Stress incontinence will often appear during viral illness with more sneezing and coughing than usual. So those are very common presentations. Symptoms only with coughing is compatible again with stress urinary incontinence, and we'll talk about that some more later. Continuous leakage after pelvic surgery is suspicious for a fistula, and it is a red flag. In the Edmonton zone, a patient like this would be referred to urology. So even though incontinence is very common, as we already discussed, and most of the time it can be managed by primary care provider very safely, certain clinical situation might require more urgent referral to specialist. And that means different things in different communities. So example of red flag situation are whenever there's a pelvic mass, hematuria, or blood in the urine. If the patient is known for a neurologic disease, for example, MS, if there is continuous leakage after surgery, as we discussed already, prior mesh surgery, and prior pelvic radiation. We have a second question for you all. Which simple tool is recommended in primary care to help classify urinary incontinence? A cystoscopy, a 3-day bladder diary, a pelvic MRI, or a post-void residual? We'll give you a couple of minutes and then we'll talk about result. Okay, so everyone seems to agree that the 3-day bladder diary is the way to go. Cystoscopy and MRI are usually specialized tests that we keep for patients with more complex situations. I think a post-void residual can be done in primary care. It's a bit more complicated, but really what you need to do is have your patient empty their bladder and then insert an in and out catheter to measure how much they retain. And I think that's something you could do whenever there's a suspicion that the patient doesn't empty their bladder well. Okay. So we're going to move on to the investigation that are relevant for someone who has urinary incontinence. And honestly, urinary incontinence is a clinical diagnosis, so investigation are minimal and really change according to the clinical presentation. So, Denise is putting in the chat that we just get a radiology to do the PVR with the pelvic ultrasound, which is a great idea. That's another great way to do a PVR. Thank you for the suggestion. As far as blood tests, you choose the blood test according to your screening needs and differential diagnosis in the moment. So it's very much related to your patient situation and the prior discussion about red flags or acute causes. At minimally, a urine analysis should probably be ordered, and I would say have a low threshold for urine culture. A 3 days bladder diary is typically helpful to gather information. Patients are usually not very good at keeping track of their bladder and drinking habits. It will probably help you with understanding better what's going on. I think we have a link to a bladder diary that's available on the HS website, and we'll put it in the chat box if anyone is interested in having a peek. If you have any doubt that your patient may not be emptying their bladder well, for example, if the incontinence presents with significant prolapse, there's a higher risk of retaining. Post-void residual may be another good test to consider. Okay, so once you've got all the information from your history and physical, and you've got your investigation, you should be able to decide what type of incontinence your patient has. If you're not confident what type of incontinence the patient has, it's actually not a big deal. Most urinary incontinence will be treated the exact same way. And if you're aware of the red flag, you're okay. There is 3 main type of incontinence encountered in women's. Stress incontinence is when people have leakage with sneezing, laughing, coughing, and exercising. Urgency incontinence is leakage of urine with a strong urge and often the inability to wait and leak on the way to the bathroom. This type of leakage is often part of a syndrome called overactive bladder and is associated with urinary frequency, urgency, and nocturia. Mixed incontinence is also very common in women, and it's the association of both the stress incontinence and the urgency incontinence. The other type of incontinence are much less frequent and are related to specific situation. Overflow incontinence is someone has challenges with emptying their bladder, and the bladder empty itself once it's like overly full. Neurogenic incontinence is related to neurogenic bladder, which is associated with neurologic diseases. And functional incontinence is often associated with issue with mobility, for example, inability to reach the bathroom on time, and such. Okay, another question here. According to the Alberta pathway, what is the first-line treatment for stress urinary incontinence? So again, the leakage of urine with sneezing, laughing, coughing, exercising. Is it anticholinergic therapy or anticholinergic medication, pelvic floor muscle training, pessary insertion, or a urology referral? We'll give you a couple of minutes and then we'll pull the answer. Excellent. Pelvic floor muscle training, 98%. My work is done here. I can just stop the presentation and go home. Very good. So let's dig into management a little bit and see if we can help Maria with her incontinence. There is generally 3 options for management of urinary incontinence. One is observation. Don't forget that urinary incontinence is about quality of life. If the patient tells you they're not bothered by their incontinence, it doesn't matter. You can just leave it alone. If the patient feels their quality of life is decreased by the incontinence, you can consider conservative management, which is everything but surgery and surgical management. All patients with leakage that are interested in treatment should be offered conservative management. That includes pelvic floor physiotherapy, education regarding lifestyle changes such as bladder irritant and good bladder habits. You can consider vaginal estrogen, medication management, and pessary as well. All these conservative measures can be offered at the same time. I think we had talked also, Alison and Analicia, that we have some nocturia tips in the pathway. I'm not sure if we're putting a link or if we're just letting the audience know. So pelvic floor.
Alison, you're muted, but I think you were speaking.
Just putting links and yeah, I'll just double check the page number for the nocturia tips and put it in the chat.
So I know we have some notes specific about nocturia and the detail. I mean, if we don't have the link, that's okay too. So pelvic floor physiotherapy, I personally think they're quite magical and they're probably your most important ally when you have a patient with urinary incontinence. Pelvic floor physiotherapy is very efficient for incontinence and it's often curative for both stress urinary incontinence and urgency urinary incontinence. So it's really, really important. Not only it helps with strengthening pelvic floor muscle, but it also improve with urge suppression. Sorry, also improve urgency with urge suppression. They can manage tight pelvic floor muscle because there's not only weak pelvic floor muscle, there's also tight pelvic floor muscle. And they usually provide a ton of education to the patients, which is very useful. There are different resources that we've put on this slide. One of the new resources are a set of pelvic health webinars that are available on Might Health. It's led by physiotherapists, and there are some sessions available into April, and every quarter more added. So if you have any patient that feel they cannot afford pelvic floor physiotherapy, because that's often the limiting factor, or they are just intimidated by pelvic floor physiotherapy, or there's some taboo around that, sometimes a webinar is an easier way to approach it. If you're interested about hearing more about pelvic floor physiotherapy, please let me know because I worked with a great team of physiotherapy and where I would be happy to organize additional teaching session around that theme. Bladder irritants are very important. They can have a big impact on bladder functioning. They include things like caffeine, alcohol, and smoking, and they can induce urinary frequency, urgency, and worsen leakage. Caffeine is one that's often not suspected by patient, but it actually has a huge impact on bladder. Patient can easily implement some technique to improve the symptoms at home. Urge suppression technique are reasonably easy to teach them. So, when the urge come, a lot of patients will just give in, but we really should be doing the opposite, which is ignoring the urge and distracting your mind. You can do that with doing some Kegels or doing mats, or there's a few different ways to tackle that. Fluid management is something quite important. You want to be drinking small amount of fluid during the day and avoid too much fluid in the evening typically. And treatment of constipation is paramount as well. Schedule voiding. I'm sure the audience will be very interested in that today because physicians and nurses tend to have poor bladder habits. We often don't drink enough water and we don't empty our bladder when we should. So a normal bladder should empty every 3 to 4 hours, not every 8 hours. Just one word about vaginal estrogen. There was quite a bit of discussion about vaginal estrogen in the last week webinar, and there will be a whole dedicated webinar about vulvovaginal atrophy and vaginal estrogen in 2026. But keep in mind that they can improve leakage and they're an adjunct to several therapies such as pessary, physiotherapy, and surgery. Just before I go to our next question, vaginal estrogen, there is a complete table in the expanded detail of the pathway. So if you need support with prescribing them, you should be able to find that table. We're currently developing a pathway about menopause, and the vaginal estrogen is being sort of aligned with that new pathway as well. Okay, so moving on to the next question. A 52 years old non-smoker with mixed incontinence has completed pelvic floor muscle training with no improvement. So this person has failed pelvic floor training. What is the next recommended step? And by pelvic floor muscle training, I mean pelvic floor physiotherapy. I'm sorry, that wasn't clear. Would you refer for surgery, start a beta-3 agonist, refer for urodynamics, start pelvic floor physiotherapy? We're going to give you a couple of minutes. So about half of you would start a medication. Which is the right answer. I think the other answer are not necessarily wrong. I think part of it is the discussion you'll have with the patient and see where she's at. I think this question was just getting at like trying to tackle the urgency portion a bit more and see if that provide the patient with the quality of life that she's looking for. So medication is also a conservative measures, and it can help significantly with urinary urgency, but also frequency and urgency leakage. There's generally two classes of medication for urgency leakage, anticholinergic and beta-3 agonist. The anticholinergic are often the first line, mostly because of insurance coverage issues. Unfortunately, there are significant side effects associated with anticholinergics, such as dry mouth and constipation. And there are also some impact on cognitive function. And so for older women, it's important to tread lightly. Patient hopefully will persevere for several weeks because the effect is not noticeable for several weeks. We usually will try only 1 or 2 medication in this class, and then you move on to the beta-3 agonist class. There is a detailed table in the expanded detail of the clinical pathway if people want more information about prescriptions. I see there's a lot of happening in the chat. I'm not sure if I'm missing anything important. It's a bit hard to follow at the same time. In the beta-3 agonist class is only one medication. It's called mirabegron or myrbetriq. It has a much better side effect profile, and the only contraindication to its use is uncontrolled hypertension. It's too bad we're limited by insurance coverage issues because it is really a superior medication when it comes to side effect. So let's talk a little bit about Pessaries next. Dr. Flood gave a great talk about Pessaries a couple of weeks ago. So for people that register, I would highly recommend watching that webinar. So this is really just a quick refresher. But Pessaries are silicone device. They're inserted inside the vagina, and they're used to treat stress incontinence and pelvic organ prolapse. They can relieve some of the urgency incontinence if it's related to pelvic organ prolapse. Most primary care provider will refer their patient out to clinics where pessary fittings are done. If a pessary fitting is successful, you get instant relief. The pessary is comfortable. And usually we are able to fit about 70% of patients with the right pessary. I usually tell my patient that pessary fitting is like shoe shopping. It's not enough to look at it on the shelf. You kind of have to put it on your feet to see if it fits. And for us, that's done by our nurse continent advisor at the clinic. There are some over-the-counter device that works well. Rest has kind of fallen off favor recently, but the Poise Impressa is widely available. It looks like a tampon. There's a sizing kit. You sort of try the smaller size first, see if it stops your leakage, and you move on to the bigger size. There's a small, medium, and large. And once you know your size, you can buy that specific package. The only downsides with that is that you have to keep buying it, right? Because they're not reusable devices. So it ended up being quite expensive compared to a pessary. In our clinic, generally speaking, pessaries are about $55, so it ended up being more cost effective. The pathway outline key indication for when referral is necessary. So we've talked already about some of the red flag that was right at the beginning of the pathway. And then you would refer to either specialized continence service or a skilled community provider for a pessary trial, as I mentioned above. And you would also refer to either specialized continence service or skilled community provider for advanced medical management and or surgical intervention. These options are usually for patients that either their incontinence persists despite conservative and medication management, or the patients that are not interested in pessary or have failed pessary fitting.
Okay, so just following through with referrals, when the pathway was co-designed, the team did work to develop a list of helpful information to include with referrals to help with triage. And so that information is like findings from the pathway. So that detailed patient history, past surgeries, medications, any results from exams and investigations, and the patient bladder diary. Also helpful to include is, any previous treatments and whether the patient is interested in going the pessary trial route or surgical intervention. We just wanted to highlight that there is a fast provincial referral pathway for gynecology, and female urinary incontinence is one of the reasons for referral listed there. You'll notice that under the process section, there are recommendations for referrals for different areas of the province. And then there's also some information, mandatory information and extra information to include. And that aligns with the information that's included in the clinical pathway as well. And I will add the link to the referral pathway into the chat just as soon as we're done here as well. So the third resource specific to female urinary incontinence is the patient pathway. And so when we develop pathways within the Provincial Pathways Unit, we often develop a corresponding patient pathway. So this is a resource for patients that you can share. It is a long-ish document, so they can access it either in a shorter version as one page, or they can pull up the full document. And I'll just mention as well that for this pathway specifically, we did develop a poster that we're happy to share, and it can be printed and posted in clinic offices if that would be helpful. And patients can use it to scan the QR code and pull it up there as well. All of our patient pathways are housed on My Health Alberta. So gynecology is an area where we've done quite a bit of pathway work provincially. So just for awareness, listing the different pathways that appear under that tab on the hub. So we have female urinary incontinence highlighted here. And as Dr. Poirier spoke to, we are in the process of developing a menopause and perimenopause pathway. And we anticipate that that should be ready early in the new year, hopefully in January. So I'll go quite quickly here, just highlighting a couple of pieces about data. So this is data specific to the clinical pathway, where we've spent the bulk of our time talking about that pathway today. So these pathways are housed in Alberta Pathways Hub. And this graph displays the access data for all pathways available on the hub since October 2023. So I think the exciting part for us is that over the last 6 to 12 months, we're happy to see an increase usage of the hub or accessing of the hub. So this slide shows data specific to the female urinary incontinence clinical pathway. This is number of downloads. So we take these a bit with a grain of salt, just recognizing that sometimes maybe primary care providers might access the pathway once, get the information that they need, and then continue to utilize that as they see patients. Sometimes they may also just get downloaded and saved to a computer, and then providers aren't coming back to the hub necessarily to access the information there. I will highlight, as Analicia mentioned earlier, just that the pathways do go through frequent updating. So it's often good to come back to the hub just to grab them from there to make sure that you've got the most up-to-date version. A bit of data about our patient pathways. So you can see from this that that patient pathway was accessed 1,457 times between October 1st and October 21st. And if we look at the first pie chart, and specifically the information in the orange, the link numbers, that tells us that the primary care providers are sharing the pathway via the link in the clinical pathway. So the resources are also quite nice because they all link together, and we've tried to make it as easy as possible to sort of be able to pull up one and then access the others. The second pie chart shows us that many patients prefer to access the full version of the pathway versus the one-page summary. And we do see a similar trend with all of our patient pathways, just that preference kind of to the full version of the information. Okay, and I'll turn it back over to Dr. Poirier after this one, but just also wanting to share that if you're interested in pathway work, have an idea for a future pathway, or want to provide feedback on an existing pathway, please contact us. We're always happy to hear from you, and we will connect with you after that. If we hear from you, you will get a response back. Thank you.
Okay, this is our last slide. Thanks, Alison. As a summary, female urinary incontinence is very common and shouldn't be considered a normal part of aging. I hope I managed to convince you that most cases of female urinary incontinence can be treated in the community. The first line therapy is conservative management, and this will help the majority of women. The Provincial female urinary incontinence pathway provide guidance for primary care providers. Anyway, that's what we were hoping for. We worked really hard on this because we were thinking about all the family doctors out there. And there's a corresponding patient pathway available to support the patient and their journey with incontinence. And we're happy to take any question you may have. I hope this was somewhat useful.
Awesome. Thanks, guys. So there's lots of questions. And so just remind people, use the Q&A. And some folks were asking, yes, there will be a pearls document. We will do that. There's a couple questions here. So Julia is asking about just some of the different devices. She says she's on the Poison Pressa website and says they've stopped making them. And it looks like that might be kind of recent. Have you guys heard anything about this?
Hi, Julia. I guess you got me there. I didn't know. I'm guessing like those are, I get marketed product for incontinence. If they don't work out, I guess if the company doesn't make any money, I guess they stop producing them. But no, I didn't know about Impressa. It's just too bad because like I don't think that it's a good long-term solution, the Impressa product, as I said, it's quite expensive, but as a short-term solution to support patient while they're waiting to access a healthcare provider, it is a good option.
Mm-hmm. And I follow one from Julia. She was just wondering about urethra.
Yeah, I see
Yeah.
it. I actually don't know. I don't think it was like an evidence-based thing. I don't think that there was any issue with the science behind it, and it was a Canadian product. I don't know. Maybe I will look it up and let you know.
And then another colleague is just asking about the role, if there's a role for Botox in any of this.
Yeah, absolutely. So we do Botox injection for women that have refractory overactive bladder. That usually means that they've tried conservative management and fail medication management. And then, yes, we do Botox injection in the detrusor muscle of the bladder.
Mm-hmm. Okay, and then Dr. Agbazy is asking around physio options, I think more in this Edmonton zone, but are you familiar with a Euro spot, or are there preferred, or is it a broad service that's available for pelvic physiotherapy?
So I think I'm not sure if the Eurospot specifically referred to one of the chairs. But there is a lot of thing out there right now. So there are a couple of special chairs that make you do like several Kegels in a short time period. The problem with those things is that there's not a lot of evidence to support them. And it's also not it's a lot of money for something that's not evidence-based. I think if you have this kind of money, you should invest it in physiotherapy as opposed to something that's not evidence-based. There's also some issue with it because when a physiotherapist does an assessment, they will assess you for weakness, but also for tight muscle, which the chair will not do. And the problem with that is that if you make someone with tight muscle do a ton of exercise, then it creates pain. And so for sure, if a patient is trying something like this, then you have to warn them that if they have any pain, they should stop for sure.
And I'm not sure, Deborah has a question here. I'm not sure what ETL Emsella is. It's an example of a type of machine that's used in some clinics.
Yeah, I think the Emsella is one of the chair. I'm actually quite sure that it's one of the chair. I'm not sure about the Euro spot. I'm not 100% sure. Maybe let me see if I can look it up.
When I looked up Eurospot, it said something about it being actually a physio place. But maybe the colleague who put the question in could clarify.
I think it's the name of the of a clinic, but it's one of the place where they're using um
Oh.
as a chair.
Yeah, okay, great. And thanks, Deborah, for clarifying. Eurospot is a chair from Tally.
Yeah.
And it sounds like a lot of the PTs are using chairs, although presumably if they've done the assessment.
Well, if there is a physio involved and they've done an assessment, I'm already somewhat more comfortable with the idea. Yeah.
And Jennifer's just asking around logistics when in the pathway when you were listing all the different places for referrals, it was Edmonton was direct to the urogynecologist. So is there a list of people taking referrals in the zone? Or is there a place, Alison, where that might be kept where people could keep an eye?
So it depends a little bit on what they're wanting to refer for. There is some clinic in the community. So there's lots of physiotherapy clinic in the community. There is some physio clinic that will do pessary fitting now. There's also some women's health clinic that will do women's health generally, and they will offer management of incontinence and prolapse. And then the urogynecology clinic at the Lewis Hall, we will provide pessary care, surgical consultation, urodynamics, medication management. So it's sort of an all-encompassing service.
Great. And then one of the colleagues is asking a little bit of a different topic around lower urinary tract symptoms with negative culture. And it looks like one of the colleagues was just sharing in the chat that there's going to be a new pathway on that soon. But did you have any sort of words of wisdom around that?
Yeah, we could have another webinar.
Yeah, probably we will, Annie. Probably we will.
Yeah, so I mean, there's a couple of different things. In perimenopause and postmenopausal age, it's often related to vulvovaginal atrophy. And so starting by treating that often will help. And then there's the other component that can be more like a chronic cystitis. So patient that have a painful bladder syndrome or interstitial cystitis may have that kind of symptoms. And then it's more tackling it from a chronic pain perspective, really.
Okay, good. Folks, keep the questions coming. I have one in the meantime, just around, thanks so much for the patient tool. Does that tool exist in multiple languages, A, and then B, you mentioned at the beginning, Annick, that sometimes some people are shy to bring up topics. Do you notice in some different groups that there might be, words of wisdom around how to broach that topic with different groups, or what have you learned from doing this kind of care?
We're talking about cultural groups, right?
Potentially, yeah, like or
With
perhaps different gender groups or things like.
Yeah, so the whole patient knowledge, taboo belief around urinary, well, pelvic floor disorders, generally speaking, is a very interesting topic. And it's one of the things that my research was based on. So when I was a fellow, when you walk in the Lowest Hall, you have 4 hallway of clinic. And the first 2 hallway are pregnancy related, and there's women of all colors and background, like it's visible in the waiting area when I walked in. And then you get to colposcopy and chronic pain, and it's sort of getting paler. And as you get to urogynecology, it's like purely white people. And I don't know what that is. And so that's why some of my research around refugees and immigrant population was from. It's been shown that pelvic floor disorders knowledge is lower and typically in cultural groups. We did a lot of work around in partnership with the Cultural Brokers Cooperative. I don't know if you know that association, but it's a community institution. And we've done, sort of presentation and webinars. It's always hard to kind of assess the impact you have. I do have some translated material, but it's not the provincial pathway. They're more like patient pamphlets and information pamphlets that I have in about 10 different languages that we've developed during my research, and I'm happy to share that with whoever writes to me. The International Urogynecology Association also has a great website with a ton of pamphlets about pretty much anything you can imagine that has to do with the pelvis, and they're all translated in several languages. I don't think we have any translated material in direct relation with the provincial pathway, but Alison and Analicia, if you have any more
Yeah,
information, I do.
so currently, all patient pathways are only available in English language, but we do acknowledge that it would be quite beneficial to have other languages available. So we've done some initial scoping on what that might look like. So that's kind of a, I would say, down the road goal for us for sure.
Awesome. No, thanks for that. Can you go a little bit more into Annick? You know, you do this all the time. You mentioned the trauma informed, and it was sort of a tab on the pathway. But could you just refresh that for everybody? And folks, feel free to put in questions. I can come up with another 5 minutes questions, but please put in more if you have some.
Yeah, I can talk about trauma inform. I think, the idea behind the trauma inform approach is to there's such a high rate of trauma in the female population, that you just assume that every woman that walk into your office is a survivor of trauma. And I'm sorry, I've been using the word woman without really explaining what I was referring to, but I think anyone that identified as a woman, really. So if you assume that everybody is a survivor of trauma, then you kind of apply this approach to everyone. I think communication is really important. You just need to have that therapeutic relationship with your patient. And if that means that you don't do a pelvic exam the first time you see the patient, that's quite all right. I think you need to give the patient the information before you're doing a pelvic exam, give them permission to be in charge. There are some very concrete tips that you can use. So, for example, the patient can have a safe word if they want things to stop. You can give them a mirror if they like that. You can dim the light. You can not dim the light. You can have a nurse in the room. In chronic pelvic pain, where I have a lot of patients that are trauma survivor, not only we dim the light and I have a nurse with me all the time, but we tell them to bring chocolate and candies. We tell them to play the music that they like, to bring a scent, like whatever that means for them. Obviously, this is a population where the trauma experience is very high. It doesn't have to be that extensive. I think the trick is, or the challenge with trauma is that you never know what can trigger something. So something that is very reassuring for someone. So for example, if I dim the light for a lot of patients, for some patient that may have been attacked in a dark alley, dimming the light can be very triggering. So really, again, I think it's about the communication piece, explaining everything that you do, giving the space to the patient to tell you what she needs. Yeah, I think that's the best I can do in a few minutes. Is that helpful or not really?
I feel another webinar coming on, Annick. We may have you, but no, thank you so much. It's really excellent. And we have probably one last question. If a community is lacking a female physician, what other options are there for patients seeking a clinical advice? So I'm assuming that that's in a context where a male physician wouldn't be appropriate, which in most communities it is, but perhaps there's some. So thoughts on that, Annick?
Thoughts on that? I don't know what's the right answer. I have a male colleague and he's very good. And we currently have a male fellow and he's also very good and well accepted by patients. So I'm not sure that being a male is a strict limitation to not take care of women's issue. Am I answering the question right, Denise? Is that what we're getting at?
I don't know what the colleague is getting at. I mean, I think my answer to this would be in the community is that hopefully you're not in a community that only has one physician. Because otherwise, hopefully you have multiple physicians and you could work with a colleague. Like if you don't feel comfortable taking care of, your female patients, hopefully you could work with a partner who is a female physician who could take care of your patient for you. Or if the patient didn't feel comfortable, that you have an option. Like we have that in our group. I've got male colleagues and we will take care of each other's patients if there's a patient for whom, it's sensitive, maybe one of my male patients or their female patients. So I think leaning on your colleagues would be my thought, but the colleague who put that in the chat, because there's no name, just maybe you could clarify a little bit exactly what you're after. And then Joanne in Edmonton. Well, again, if it's in Edmonton, there's a lot of physicians of every stripe known to man. So presumably we could have, work together as a bigger team to find a place for that patient to be so that they're comfortable. If that answers the question. So great question. I'm glad people are bringing this up because it is a barrier, right? Sometimes people feeling uncomfortable. And it's tricky. And if people aren't coming to care, then that's a problem. And I think Aniola's kind of weighed into this a little bit in the dysfunctional uterine bleeding webinar that's upcoming. She's our Black Health lead. And, there's a tremendous amount of trauma that has happened in community. And that does have people not coming to care because of that. And so what can we do as a broader health community to make safe spaces for people to be able to feel like they're comfortable to come get care when they need care? So those will be great questions to take up at that webinar. And we're at time. So thanks so much, guys. We will send out folks. There's a whole bunch of comments in the chat. It's been active today. Everyone's now saying thank you. But so for people who are interested in working on pathways, Alison's put the email in there. So Sadia, that's in there. There's lots of stuff, and we'll compile all this together with the colleagues in the Pearls document so that we can send that out to everybody. And then don't forget the pathways right there on the pathways page in all of its beautiful detail. And Alison, I'm feeling maybe a PLP project coming on around, we do a lot of work with MCHB, so maybe there's a project on how we expand these tools and resources for more folks in our community because they're so great. So congratulations on all of the great work. Thank you so much for the awesome presentations and for the